So welcome, everyone. This is a webinar today on building pathways to sustainability. This webinar is brought to you by the Arch Sustainability Learning Collaborative, but we thought it was an important enough topic that we've opened it up to all of you, all the Lifespan Respite grantees and your partners. I'm Jill Kagan, as most of you know. I'm Program Director of Arch, and we are really delighted to have all of you join us this afternoon. As I mentioned, everyone's hopefully going to stay on mute and remain on mute while we have our presentation. And I think we'll try to do most of the Q&A in the chat box just because we're expecting a fairly large number of people on the call today. And that'll also prohibit us from doing formal introductions. If you didn't sign in to Adobe Connect with your name when you logged in, please type your name in the chat box so we can make sure we know everyone who's with us today. As I mentioned, we'll have time for questions. Marisa has agreed to stop during some parts of her presentation to see if we have any questions, but we'll hopefully also have time at the end for questions. So whenever you think of one, feel free to go ahead and type that question into the Q&A box in the corner of your screen. If you would like to see the PowerPoint slides in full screen mode, you can click on 4 arrows that are pointing outward in a small square in the right-hand corner just above the slide presentation. We will make the recording of the webinar available in the next few days and send you the link to that. If you want to download the PowerPoint presentations immediately, you can do that right from this webinar platform. If you see the pod titled Materials on the right-hand part of your screen, you can click on that document and then select Download Files. And please, as I always ask you, check your email immediately following the webinar. That will direct you to a survey link so that you can give us your feedback on today's webinar and also provide us with any future topics that you'd like to see webinars or teleconferences on. We are, as always, very dependent on and grateful for your input. So thank you in advance for responding to that link. I do have, just as usual, a few quick announcements. First, registration is now open for the National Lifespan Respite Conference that will be held next May in collaboration with our wonderful partners, the New York State Caregiving and Respite Coalition and the New York State Office for the Aging. Just this week, we posted a preliminary conference program if you want to take a look at the speakers and more details about the breakout sessions. And I also wanted to let you know, for those of you who don't yet know, registration has opened for the Lifespan Respite Grantee and Partner Learning Symposium. This is a meeting by invitation only for the grantees and their primary partners. The meeting will take place the day before the conference. If you are a current or former grantee or a primary partner and you did not receive your invitation from me and Victoria at ACL, please let me know and I'll forward that to you again. In addition to registering for both of these events, I also encourage you to reserve your hotel room as soon as possible. We always have a limited number of rooms at the discounted conference rates, and they're available on a first-come, first-served basis. So even though the hotel is making them available through mid-March, I'm very certain that they will sell out way before that date. And finally, I've been alerting everyone to this, but the name of the hotel has now officially changed from the Adams Mark to the Buffalo Grand Hotel. And if you already made your reservations, that doesn't change a thing. It's just a sign out front. Nothing else about the conference venue has changed. Again, if you have any questions about the conference, send me an email or type it in the Q&A box, and I'd be happy to respond to you. I wanted to let people know we've added another Sustainability Learning Collaborative webinar on March 6th at 2 p.m. And we're really excited about this. Cassandra Furman, who many of you know from ARCH, she's also with the Friends National Resource Center, will be joined by Mary Jo Caruso from Friends. And Mary Jo did that wonderful webinar for us last fall on volunteer respite. And they're going to be talking about tools for conducting cost analysis of respite services. And hopefully we'll get into some discussion about how you can use that specifically for your lifespan respite activities. We know that being knowledgeable about cost analysis and developing the skills to carrying it out can be really an important component of any sustainability effort that you're working on. So I encourage all of you to join us for that. It is a Sustainability Learning Collaborative webinar, but again, we will open it up to all of our grantees and partners. Again, that's March 6th at 2 p.m., and I will send around an email about that. And in the same vein, the Sustainability Learning Collaborative, our small working group whose members are developing their sustainability plans and networking about that, will resume their monthly meetings this Friday at noon Eastern Time. And you should have received a calendar invitation about that for the handful of you that are on that small work group. And finally, you may have seen over the last few months our many emails soliciting applications for innovative and exemplary respite services. And I wanted to let you know that we did receive quite a few very impressive applications, and we're currently reviewing them for inclusion on our database of exemplary services. And we hope to announce those that were selected by February 15th. Up to 3 of those who are selected that have demonstrated outstanding innovation, we're going to invite to be recognized at the National Lifespan Respite Conference in Buffalo. So we're very excited about this initiative, and this will not be the only call for applications. Probably next May or June, we'll start the process again to keep building that database of wonderful services that we're learning about. And now I think, not seeing any questions in the Q&A box about any of that, we'll move on to our topic today. I know a lot of you, so many of us in the field are talking about the need for community-based organizations and state agencies also to start developing some business acumen for their own sustainability needs, but also so they can be responsive to the needs of the family caregivers they serve, since so many services are now moving into the private sector and provided through the private sector. And there are so many rapid changes that are driving this need. States are moving to Medicaid managed care, and as many of you know, Medicaid is still the largest federal payer of respite. More and more healthcare providers and payers are recognizing that social determinants and social needs are just as important as medical interventions for improving health status. We have new ruling from Centers for Medicare and Medicaid around Medicare Advantage plans that are now able to provide home care and respite and other supplemental services. So we all really need to be able to first identify who the right players are that we should be talking to, such as managed care organizations, hospital systems, long-term care providers, health insurance plans, and then start to develop some skills so that we can converse with them about the benefits of paying for respite care and how to contract for those services. And we all want to be at the table for those discussions. So I'm really so pleased today to introduce our speaker, who's taken time from her extremely busy schedule to join us. Her name is Marisa Scala-Foley, and she's the director of the Aging and Disability Business Institute at the National Association of Area Agencies on Aging, more commonly known as N4A. And this institute is providing community-based organizations with tools and resources to successfully adapt to a changing healthcare environment, enhance their organizational capacity, and capitalize on emerging opportunities to diversify funding, all things that we're really concerned about. Recently, she served as director of the Office of Integrated Care Innovations in the Center for Integrated Programs at ACL, where she managed the agency's efforts to build the capacity of state and community-based organizations for delivery system reform. Marisa has worked her entire career in the field of aging on issues related to health care and long-term services and supports. And I welcome you, Marisa. We're so grateful for your time today, and I know all of us are very eager to hear your presentation. So I'm happy to turn it over to you.
All right. Thank you so much, Jill. Thank you both for the kind introduction as well as for the invitation to talk with this terrific group today. I'm thrilled to have so many people on the line and to see the interest that you all have in this work of generating sustainable revenue sources and in connecting and partnering and hopefully contracting with healthcare providers and payers. This is sort of our bread and butter here at the Aging and Disability Business Institute. It's what we do every day. It's what I did for the, sort of 8 years before that when I was at the Administration for Community Living. It was a large part of what I did every day. So this is an issue that's near and dear to my heart, and I'm thrilled to be talking with you all today. Let me just make sure, because I am speaking through my speakerphone, can you all hear, Jill, can you hear me okay?
Yes, you're coming through very clearly. If someone else is having a different experience, please let us know, but it sounds great to me.
Okay, excellent. All right, so let's start talking a little bit about us at the Business Institute. Our mission at the Aging and Disability Business Institute is to build and strengthen partnerships between community-based organizations like yours, and I understand a number of you are from state agencies as well, and I'll talk a little bit about that later, and the healthcare system so that older adults and persons with disabilities have access to services and supports that will really enable them to live in their homes and communities for as long as possible. We are, I'm not going to go through all of these names, but we have a number of different funders. We are funded not only by ACL, but also by the John A. Hartford Foundation, the SCAN Foundation, Gary and Mary West Foundation, and the Buck Family Fund of the Marin Community Foundation, and the Colorado Health Foundation. And we partner with a number of national and community-based aging and disability organizations that you see logos for here in order to do the work. So this is our work. Our work is really, we are a national resource center that seeks, as I mentioned before, to build the business capacity of community-based organizations to partner and contract with healthcare entities. We do that through a number of ways, through the provision of training and technical assistance. We have a robust readiness assessment tool that community-based organizations can use to determine their sort of capacity, where they are strong in different areas related to contracting with healthcare entities and where they may need some capacity building. We do targeted outreach and education with the healthcare sector, and we also ultimately seek systems change, because we believe that in order to build an effective integrated care system in a community or a state or a region, that has to involve community-based organizations, because you all are the ones who have the decades of experience in your communities, who work every day with older adults and persons with disabilities and caregivers in order to deliver these services. So that is part of what we do and the work that we do every single day. So really quickly, you have a screenshot here on this next slide of our website. This is where not only our readiness assessment tool is housed, and you can see in tiny print on there, it's a little bigger on your screen when you go to the website, obviously, that our readiness assessment is on here. We have all of the resource guides and tools that we develop, case studies, resource guides, other kinds of tools that we have developed are all available here on the website. They are open to the public. It is not purely for N4A members, but rather for any community-based aging and disability organizations that are really interested in this work. So we started with this work in terms of looking at the movement toward integrated care and the delivery system reforms that are happening in states around the country, whether it's managed long-term services and supports through your state's Medicaid program, or accountable care organizations, or certainly in places like New York State and other states, the DSRIP, the Delivery System Reform Incentive Programs, or any of the mechanisms that exist for bringing together the healthcare and the long-term services and supports, or the social service sector. We believe that community-based organizations can add tremendous value to those delivery system reforms that are happening around the country. And whether it's, and this slide looks at what we know are some of the major drivers, both of quality and cost when it comes to these delivery system reforms. And we look at the kinds of services that aging and disability organizations provide and where they might add value when it comes to some of those drivers of cost and quality. So just really quickly looking at preventing hospital admissions and readmissions. You see it on the side to the left, all of the services that we know of that community-based aging and disability organizations provide, whether that's certainly caregiver support services, evidence-based care transitions, medical transportation, and on, that can really help with that particular driver, to keep people out of the hospital when it isn't necessary for them to be there. So we believe community-based organizations can add tremendous value when it comes to the changes that are happening within the healthcare and long-term services and support systems. So part of what we do at the Business Institute is we really wanted to get a lay of the land, so to speak, in terms of the extent to which these partnerships were happening between community-based organizations and healthcare entities, whether those are health plans, health systems, hospitals, accountable care organizations, physician practices, and more. We wanted to see what was happening and then what progress was being made. So we've done 2 of these requests for information surveys. Hopefully some of you have either seen or filled them out when they've come across in your email. But we did one in 2017. We did another one in 2018. I wanted to share some of those results with you in terms of what we found in 2018 and where we saw progress being made between 2017 and 2018. So this is a little bit about the survey methods. I'm not going to spend a lot of time on this because I really want to get at the heart of what we learned, what we are learning, and where we think there are opportunities for community-based organizations to engage, and the kind of questions you need to think about as you embark on this journey. But you see that how we partnered with Scripps Gerontology Center at Miami University on the survey, and you see some of the things about the methods that we used and what we saw in terms of respondents. Looking at area agencies on aging, centers for independent living, as well as other community-based organizations. So let's get at some of the results. The good news is that we saw an increase in contracting in just under a year. So the request for information survey in 2017 went out in late summer 2017. The request for information survey in 2018 went out in late spring, early summer. So it was probably around 10 or 11 months between the 2 surveys. And we saw that the number of organizations, or the proportion of organizations that said yes, currently had 1 or more contracts, went up by 3 percentage points, from 38.1% to 41.3% of the organizations who responded they had contracts. And another encouraging sign, the number of the proportion of organizations that said they did not have a contract and weren't interested in pursuing them all went down, about 3.5%, or from 45% to just about 42%. So we're seeing, positive trends in terms of some of this. This next slide shows some of the most common healthcare partners for community-based organizations, and overwhelmingly it tends to be, a lot of this contracting has been very Medicaid focused, as you might imagine. There's certainly a lot more latitude within Medicaid programs for the kinds of services that community-based organizations offer, more so than we've seen in Medicare, but I'll talk a little bit about how that's changing and where some of the opportunities lie. But 41% of the organizations that said they had contracts indicated that they had contracts with Medicaid managed care organizations. Next on the list were state Medicaid agencies, that did not have managed care.
Oh my God.
If we could get folks, I know Jill had reminded everybody, we're getting some background noise. If I could ask folks, if you haven't already, to put your phone on mute, and maybe Jill, you can remind them how they go about doing that. I thought it was *6, but I'm not entirely sure.
Yes, please hit *6 to mute your phones. Thank you.
Thank you. But we also see Medicare, there's some of the duals plans, as well as accountable care organizations, VA, and so forth on this list. Interestingly, Medicare Advantage plans, were toward the bottom of that list in terms of the most common healthcare partners, but increased by 3.5 percentage points between 2017 and 2018. Given what we're going to talk about later in terms of the changes that are happening with the Medicare Advantage supplemental benefits, we anticipate this rising in the future. So the most common services provided through these contracts between healthcare entities and community-based organizations, care management, care coordination, service coordination, certainly at the top, also care transitions and discharge planning, and you see the list go on and on. I did want to point out, that in 2018 we saw that 20% of the organizations that had contracts that indicated that they had contracts with healthcare entities indicated that they were providing caregiver support, training, and engagement services. With that, we also that was separate from respite care, and respite care, 11.5% of the organizations that that indicated that they had contracts were offering respite care. So respite care was definitely on there. I don't have information in front of me that would show a difference between time 1 and time 2, but if folks are interested in that, I'm more than happy to sort of dig that up in terms of the change any change that we might have seen between 2017 and 2018. But I did want to point that out. So in terms of we asked about the most common changes that were experienced by community-based organizations that had contracts. And not surprisingly, at the top of the list was exactly what we're talking about today in terms of sustainability. 55.6% of the organizations who responded said that they, by virtue of this contracting, they were able to obtain funding from new sources. And about 25% indicated that they had increased their agency's net revenue. The other sort of positive changes was expansion of their visibility within the organization, being able to increase the number of people that they were able to serve, as well as expand the types of populations that they were able to serve, and enhancing their organization's sustainability. So we also asked about challenges. What were the top 5 challenges in contracting? And we asked this, we divided the results up by contracting status. So organizations that had contracts, organizations that didn't have contracts but were pursuing them, and organizations that did not have contracts and were not pursuing them but had tried and were unsuccessful. So you see, there is some commonality across. There are 3 specific challenges that were indicated that appeared across all 3 populations. Common understanding of proposed programs and services. There's sort of we talk about this sort of mismatch sometimes between the language that healthcare providers use and the language that social services providers or long-term services and supports providers use, and how there's sometimes a disconnect. They could be talking about the same thing but using different language. Also, attitudes of healthcare professionals towards your organization appeared in all three groups. And then finally, integration of your organization's services into the healthcare system's workflow. Because what we've learned over time from the community-based organizations that we work with is that, a contract is terrific, but if your, referrals between the healthcare entity and your organization aren't part of the workflow of the care manager at the hospital who's making that referral, it isn't part of their workflow, then having that contract doesn't matter if you're not generating any volume, if you're not getting any clients that you can serve that allow you to then potentially, to build the healthcare organization and to generate that revenue, those sustainable revenue sources. So, a lot of this is very much, why do this? And that's often where we start on some of this as I've gone out and done presentations on webinars and at conferences. It's both that, in the picture you see on here is a woman with a nun with the Catholic Health Association, whose name I'm totally drawing a blank on right now, but who sort of coined the phrase "no margin, no mission." So in part we partner, community-based organizations are partnering with healthcare organizations because it does give them an opportunity to generate those sustainable revenue sources or to generate margin. But more importantly, this does fit with the mission that community-based and state aging and disability organizations have. It presents an opportunity to build a more seamless, responsive, person-centered system that can better serve older adults, persons with disabilities, and their families. So some of the things that we found that work when it comes to this partnerships or developing these partnerships and contracts. First, finding and nurturing champions. Finding that person or people within the healthcare sector, within the organizations with which you're trying to contract, who get the value that your organization can bring to their organization, who speak both languages, who understand the importance of the services that you deliver to caregivers and to older adults, and who can help you to get your foot in the door. That will lead to the first meeting, that will lead to the second meeting, that hopefully ultimately will lead to the contract with that particular healthcare entity. Having a shared vision and mission. When I started this work at ACL, we were sort of doing a lot of this capacity building, with the idea that pretty much any contract was a good contract. And we quickly learned that that wasn't necessarily the case. It's critical that the organization with which you are seeking to sign a contract share your mission and vision in terms of, getting the right care at the right time in the right setting to older adults and their families. So what else works? A common understanding, and this probably is going to sound silly, but a common understanding that community-based services are not free. And I say that, sort of laughing a little bit because one of the, when I was at ACL, our administrator at the time, Kathy Greenlee, had a meeting with someone, higher up in leadership at Health and Human Services, and we always joked that, we completely understood what community-based organizations were trying to deal with within the healthcare sector, that you always sort of feel like you're raising your hand and going, pick me, or make people aware of what you do and how important it is, because we used to have to do the same thing within Health and Human Services, as ACL was sort of 200 people within the larger sea of 80,000 people who work for Health and Human Services. So, and one of the things that person within, senior leadership at Health and Human Services said to Kathy was, "Oh, I know who you all are. You all are those free people in the community." Well, you all know this. These services that you're providing are not free. Someone pays somewhere, whether it's via the Older Americans Act or other kinds of grants that you might have and so forth, but those are limited resources. And that if your organization is providing services to caregivers, to older adults, to persons with disabilities that can help a healthcare organization to better to hit their quality benchmarks and to potentially generate cost savings, you all ought to be paid for that or have a share in those savings. So what else works? Certainly flexibility in terms of services and how they're delivered and so forth, as well as a laser focus on your partners, what we call pain points. What keeps the healthcare organization that you're working with up at night when it comes to serving their members, serving their patients, and so forth. And then finally, data sharing is really critical in terms of not only a community-based organization getting the healthcare organization the data that they need in terms of the services that they provide and the kinds of results that they're getting, but getting that data back. Getting data back from the healthcare organization that allows you to troubleshoot, to do performance management and measurement, and so forth. So some of the things that we're looking at going forward, and then I want to get to some of the building blocks of this work, really are understanding the decision, because healthcare organizations have a decision to make here. Are they going to build these kinds of services themselves? Or are they going to do what we all hope that they'll do and purchase those services from community-based organizations who know their communities, who know the populations that they're serving, and who have been doing this work for decades. We want to one of the things that we're focusing on is really responding to some of the new payment models and opportunities that exist, whether those are value-based payments or, as we'll talk about later, the Medicare Advantage supplemental benefits. Preparing organizations to accept risk, and then also looking at this issue of referrals and volume that I talked about earlier. So where is it important for you all to begin? So one of the things that we've talked about, is sort of these building blocks when it comes to that journey toward building your capacity for partner and contracting with healthcare entities. And one of them, so I'm going to walk through a number of these. We're going to look at some of the key questions that you need to think about really quickly, and then we'll talk some more about some of the opportunities that exist. But one of the fundamental building blocks on this is organizational culture. One of the most important lessons that we've learned in this work is how much culture matters. Because in a lot of ways, I'm sure none of us got it. I have a master's degree in gerontology. I've worked in the field of aging for my entire career, as Jill pointed out. And I'm willing to bet that, I certainly didn't, none of you got into the field of aging because you thought, aging services, that's where the money is. So in a lot of ways, this shift toward really generating sustainable revenue sources and building business acumen, feels like this cartoon that you see on the screen. What I'd like for you to do is to change everything about yourself and get back to me. So this involves this shift, and you see this quote from Peter Drucker here on the screen that, you can have the best strategic plan or business plan in the world, but if your organizational culture isn't ready for this shift, culture eats strategy for breakfast. So this involves commitment at all levels, at the staff level, at the managerial level, certainly at the executive level, and at the board level, as well as commitment from partners, too. And we're talking about a culture that it has an expanded view of who your customers are, both your clients, whether those are older adults or caregivers or persons with disabilities, and payers. Potential contracting organizations are also your customers as you engage in this work, and who your competitors and partners are. It involves not necessarily, I've heard at AAA, actually, Roseanne DeStefano, who used to lead elder services in the Merrimack Valley, AAA in northeastern Massachusetts, talked about, she said, not data-driven decision-making, but data-informed decision-making. We need an understanding of costs, and I was thrilled to hear Jill talk about your next webinar, which is really going to look at some of these issues related to cost, and certainly this focus on outcomes, quality, performance, and results, and having the systems in place that will support this culture. And then finally, vision and innovation and excitement. This is challenging but exciting work. It's an opportunity not only to think about your organization as you fit into sort of the delivery system reforms that are happening in your state, but also how we can build that better integrated care system that we all want, not only for the clients whom we serve, but also for our families and ourselves. So other building blocks, market analysis, understanding your market, the existing market, how it's changing, who your customers are, what do they want and need, what are you good at, what is your organization or your network, where are you strong, and where might you need some help, who your competitors are, and any regulatory or political factors that might impact your ability to deliver service and get contracts. Another building block, service lines or packages. What services does your organization or your network have the capacity to deliver? What's your history in that area? What is your organizational stature in the market? Another critical piece, developing your value proposition. Why should a healthcare organization buy your services? What is the business case that you can make for them buying your services? Being able to communicate your services and value clearly and consistently, both through data that you might have, return on investment information, and stories that you have of the clients whom you've helped, of the older adults and families whom your services, how your services have made a difference in their lives. They need to know both of those. And how your services that you offer, your organization offers, can meet your customers' needs or solve their problems. So relationships, we talked about this before in Champions. This work is, in addition to organizational culture, relationships in this are critical. Who's in your network, if you are, trying to put together a community-based network, and who isn't, but who might need to be based on the needs of either the populations whom you're serving or the contracting organizations whom you're targeting, and who your champions are. And I talked a little bit about that before. Infrastructure is important as well. Do you have the infrastructure available that can, to handle referrals, billing, tracking outcomes? Health information technology is a really important piece of this, both in terms of being able to communicate among your partners within the community, being able to communicate with potential contracting organizations, as well as, how you're going to bill and transfer information. Pricing and cash flow, there's some considerations certainly here on the screen, but it sounds like you're going to dive into this a lot, looking at on your next webinar. What does it cost to deliver the service, your direct costs, what margin can you add in there in terms of an indirect rate, what is the market willing to bear in terms of the price of those services, and the value that that service can have for a potential payer. Volume. So I talked a little bit about this before in terms of workflows, but how will you generate and sustain client volume? What will that referral process look like? How can you generate staff-level buy-in with the contracting organization with which you're working to be able to get those referrals that will enable you to, generate volume, generate revenue, and serve a larger group of people? And how might you meet potential demand when it comes to staffing and partnerships? And then finally, quality. How are you going to track the quality of the services that you provide, both in terms of process and outcomes? What will you use? How will you use what you collect in order to manage performance? And how can this factor into the quality measures that a payer might need to make, whether those are STAR quality ratings, HEDIS, and other kinds of reporting systems, and so forth. So what is the value that community-based organizations bring? We talked about the kinds of services that community-based aging organizations deliver that we believe can add value, but what is that value? It comes in the form of, as we were talking about just before, return on investment. It comes in the form of helping a potential contracting organization to be able to hit their quality benchmarks, whether those are STAR measures or measures related to Medicare hospital compare, HEDIS measures, and so forth. The value can come in the form of cost savings, or if not cost savings, sort of costs in the right areas. So rather than spending money on a hospital readmission, being able to put those dollars toward services that can help people, older adults and persons with disabilities, to remain in the community where they want to be. Avoiding penalties that a hospital or a health system or a health plan might face. And then finally, I think you all can, community-based organizations bring real value in terms of, consumer or patient or family activation, as well as their satisfaction. The kinds of services that you deliver are high-touch services that, enable a health plan members to really feel like their lives are made better by those services. Those are the kinds of services that community-based aging and disability organizations deliver. All right, so really quickly I want to go through a new opportunity I alluded to before in terms of Medicare Advantage. So last year, as you all may know, the Budget Act that President Trump signed into law early in the year included provisions that were under the Chronic Care Act. And that did a number of things related to integrated care, but most importantly looked at the expansion of Medicare Advantage as supplemental benefits that Medicare Advantage plans might be able to offer to their members. This includes the flexibility to offer some types of long-term services and supports. So the changes that are happening with it for Medicare Advantage plans, and I'll talk about these in a little more depth on the following slides, include changes to the uniformity requirements, changes related to how they can target these services to beneficiaries, and how they define what are called primarily health-related services. So some of the changes that we saw, so the law was passed in 2018. It indicated that these benefits could start in 2019. There are changes that are happening in 2019 as well as in 2020. So in terms of the uniformity requirements I talked about before, the old rules that govern Medicare Advantage plans said plans had to offer the same benefit to all enrollees of the same plan. In 2019, Medicare Advantage plans are now allowed to target these benefits to groups of enrollees who share certain diagnoses. In terms of the supplemental benefits, the old rule said the supplemental benefits must be primarily health-related, which meant in part that they couldn't be for the purpose of daily maintenance, so addressing activities of daily living and so forth. And the new rules give a broader definition in terms of what primarily health-related means. So what is that? So these benefits, the new rules say that these benefits must diagnose, prevent, or treat an injury, can't compensate for physical impairments, act to ameliorate functional or psychological impacts of injuries or health conditions, or reduce avoidable emergency or healthcare utilization. So a much broader definition. They cannot, however, be solely or primarily used for cosmetic, comfort, general use, or social determinant purposes. So, if the only reason why a person is getting a service is because, it has to tie back to one of these first four bullets. So being able to either improve functional impacts or to, avoid functional decline or reduce avoidable emergency department use or healthcare utilization. And these benefits have to be recommended by a licensed professional as part of a care plan. So examples of some of the allowable types of supplemental benefits, and I've highlighted a couple that clearly relate to the work that you all are doing as you provide respite services, respite care, certainly, as well as support for caregivers. But you see some of the others on the screen, including adult daycare, transportation to doctor's visits, home modifications, and more. So what are we seeing right now in 2019? Well, given that the answer is not a lot, particularly when it comes to in-home supportive services, such as the ones I was detailing on the slide before. While a fair number of plans are delivering services, you see the overwhelming majority are offering benefits, that are offering these benefits are offering nicotine replacement therapy. Now, in large part, we think that this sort of slow uptake on some of these other services have to do with when the Chronic Care Act passed in relation to when plan bids were due. So typically Medicare Advantage plans submit their bids to the Centers for Medicare and Medicaid Services in June of each year. And the law passed in February, which did not give them a lot of time to, think about what the benefits are that they might offer, to build their networks, and so forth. So we expect that this will increase in the future. I will say one of the bright spots as it relates to the kind of work that you all do is that 13% of the plans that are offering new supplemental benefits are offering support for family caregivers, which says that there is absolutely an appetite for the kinds of services that your organizations offer related to respite, family caregiver training, things along those lines. We expect to see this go up in 2020 and beyond, assuming the rules don't change in some other way. So there are more changes expected in 2020, a further expansion of supplemental benefits to allow benefits that, and I quote the law here on the screen, that with respect to a chronically ill enrollee have a reasonable expectation of improving or maintaining their health and overall function, and may not be limited to being primarily health-related benefits. So, even a further expansion. And the Secretary can waive the uniformity requirements for these for supplemental benefits to chronically ill enrollees. So where are there opportunities for community-based organizations in all of this, and some sort of advice, that we've offered and that we've heard others offer in terms of this? First of all, defining how, part of this involves homework. If you're targeting a particular health plan or healthcare entity, you need to know what, as I mentioned before, sort of keeps them up at night. Maybe it's getting people, to a follow-up appointment after a hospital discharge, or any of a number of different pain points. So you need to define your value proposition, what you can bring to their organization in terms of how the services that you offer can address their needs. Certainly results. Not only, results from your current work, but also results from, any contracts or pilots you might engage in with healthcare entities. Some advice that we've seen in terms of approaching Medicare Advantage plans, if you have existing healthcare partners, think about engaging them in your approach to a Medicare Advantage plan. And if you have a contract, if you have worked with the Medicaid or duals plans in your state, think about approaching their Medicare Advantage plan. Because you have a track record with them, their Medicare Advantage plan might be more amenable to potentially contracting with your organization. And the final point I have on here is really don't underestimate the value of retention, particularly as it relates to managed care organizations, health plans. Once they have someone enrolled in their plan and have done the, initial assessments and have really gotten to know this person and so forth and potentially know what their needs are, they don't want to lose that person to another plan. And the kind of high touch services that your organizations offer can really help to boost their consumer satisfaction and help them to keep members and not lose them to another health plan that may be in your state. Okay, one additional thing that I wanted to address, because Jill had mentioned to me yesterday, is that a number of you may be with state agencies. We're seeing, there have been, in a number of states, there have been state agencies that have engaged in this work. While they might not be the ones who are necessarily contracting with a health plan or a healthcare entity, there's much that states can do that can help to help the community-based networks, whether it's area agencies on aging or other aging and disability, community-based aging and disability organizations within their state. We are working with a couple of states right now with the state unit there in terms of building business acumen training programs for the community-based organizations within their state. States can also play what I've heard someone refer to as a matchmaking role, because states are the ones, state Medicaid agencies are the ones that are signing the contracts with health plans within their state. So your state Medicaid agency, hopefully in partnership with a state unit on aging, can help to really, tout the value that you all bring, that community-based organizations can bring to these plans, and help to make introductions and so forth in terms of matching up the good services that your organization provides with what the needs, with that health plan or health plans that are coming into your state. So we think there are a lot of roles. There are a number of different roles that state agencies can play in this work as well. So I just wanted to, even though it wasn't explicitly mentioned in my slides, I wanted to make sure that I covered that a little bit as well. But with that, I think we have about 10 minutes left. I wanted to turn things over to Jill to see if we have any questions.
Yes, thank you so much, Marisa. That was extremely informative, and for a novice like me who doesn't know much about any of this, I found it very helpful. We do have one question from Patrick, and he wants to know if you're currently aware of a Medicare Advantage plan that's offering respite on a larger scale.
So what we really want to do is, now that we're in the 2019 plan year, is really to kind of dig under the hood of those sort of overview numbers that I mentioned to you earlier, especially that caregiver services, because we have not seen a lot of contracting in that area with community-based organizations, thus far. We've seen a lot more related to care management, care coordination, and care transitions and so forth. So while the answer is I don't know of one right now, it is some work that we are looking to do as we engage more in this work in relation to Medicare Advantage plans. So we will do some kind of digging around under the hood of what those numbers actually look like with Medicare Advantage plans, and then circle back around with Jill to share what we've learned in relation to respite services.
That would be great. Thank you. Are there any other questions? I think if some of you don't want to type, we could, and you're in control of your own mute and unmute button, if you wanted to unmute your phone and actually ask the question, that would be fine as well. Well, I don't see any, but I have a few questions myself, if that's okay, Marisa.
Sure.
You started to talk about strategies that state agencies could engage in that might be different than the community-based organizations, and I found that very helpful, especially in terms of being able to perhaps introduce the community-based organizations and their coalitions and their networks to the relevant people. But I'm wondering, for those of us who are really new at this, how do we begin to identify who it is in the Medicaid managed care plan or in the health insurance plan or in the Medicare Advantage plan? Who do we identify that we can start those conversations with?
Yeah, that's a great question. I think the answer is to start with where you have existing relationships. And if your organization doesn't per se, if your leadership doesn't, your board might. And you might seek to try to build those relationships to try to get someone, from different healthcare entities and healthcare organizations on your board so they can learn more about what you do, because that relationship building piece of this is really important. So starting with the existing relationships that you have is really a good place to begin in terms of some of this work, because that's the person who can help to be a champion for you and get your foot in the door on some of this work. In terms of sort of starting from scratch, certainly being able to make your case not only to senior leadership within a particular health plan, whether it's the chief medical officer or the a person who's in charge of either care management or nursing services and so forth, but also being able to make the financial case or the business case, for what you do. So being able to have that messaging that will appeal to, folks who are engaged on the service side as well as on the financial side of this. So, but start with who you know or who your board or your partners know on some of this is certainly, I think, in some of the early learning collaborative, business acumen learning collaborative that we did when I was at ACL, we had worked with 20 different organizations that ultimately generated 30 plus contracts with different healthcare entities. I think all but one of those contracts came as a result of, someone knew within their organization who got them that initial meeting that led to future meetings that ultimately led to a contract. Very few came from, a request for proposals that a particular plan put out. So starting where you live, I guess, is probably the best advice I can offer.
Yeah, and one thing I think our grantees and partners have expertise in is building relationships. Absolutely. And networking. So they probably don't need a whole lot of guidance on that, but that was very helpful, at least since it's a whole new arena of people that they probably don't yet have in their networks, that their networks can still help them make those connections, I would think. Also, in terms of tools that you might have on your website or that you could make available are things like actual samples of contracting language. Is that something that, getting really down to the basics of how do we do this work? And maybe not even knowing what a contract is or how it should read.
And we do have some of that information available on our website. If you look at, it's on our homepage, there's a number of different, on the left-hand side of the screen, there's a number of different resource categories. So certainly in the Evaluate Contracts section that we have some examples of, contracts as well as, advice from people who have gone this route, as well as memoranda of understanding between community-based organizations and potential partners or subcontractors. So we do have a number of that information. All of that information is available to the public. So, we invite you to kind of explore some of those resource categories to look for some of that information.
Great, thank you. That's very helpful. And any other questions from the field? Well, before we close, I have one more last basic question I was just starting to worry about while you were talking about Medicare Advantage plans. And I wonder if you could just really briefly, for those of us on the call who may not really understand what a Medicare Advantage plan is and how that differs from traditional Medicare, and why this is so absolutely revolutionary, given that Medicare has traditionally never paid for any long-term services and supports. And how many people this will affect? How many are served by Medicare Advantage plans versus traditional Medicare?
Sure. So about the number of Medicare beneficiaries who. Let me back up really quickly a step. When people people who have Medicare can either get their services via what's called original Medicare, which is traditional, sort of fee-for-service Medicare, where you pay, Medicare pays by the service. So a person goes to the doctor, they would pay the doctor for the particular service delivered, or they go to the hospital and so forth. Medicare would pay for the hospital or a portion of that hospital's expenses. They also have the opportunity to join a Medicare Advantage plan, so a managed care organization or a managed care plan that receives, a set amount per month to cover the care for the beneficiary who is enrolled. And those payments, those capitated payments are, adjusted in terms of risk and, sort of how if a person has, higher needs, they might get a higher payment. Plans receive a higher payment for people who are duals, because duals tend to have more healthcare needs and more and utilize more services. The proportion of Medicare beneficiaries who are enrolled in Medicare Advantage plans has increased fairly steadily, particularly within recent years. I believe the last figure I saw was roughly about a third of Medicare beneficiaries are enrolled in a Medicare Advantage plan. So it is a growing proportion of Medicare beneficiaries who are enrolled in these plans. So we think that there are, some pretty strong opportunities that are here, as I talked about before, for community-based organizations.
That'll probably grow as more people learn that through Medicare Advantage you can get some of your long-term services and supports covered. I would think that might be incentive.
It absolutely could be an incentive, and also as more people sort of age into Medicare who have experience, with managed care plans, who may have gotten, who may have been enrolled in a managed care plan as part of employer-sponsored benefits and so forth. I think we'll continue to see that number rise.
Right. I want to, before we close, I'd like to know, is there anyone on our call, and you can type this in or unmute your phone, if you have been at the table with your Medicaid managed care program or your state agency that's working with a managed care organization to help develop these contracts. And if any of you have been successful in talking to them about respite or caregiver supports. Is there anyone on the call who might want to share their experience? I know there are a few of you that have, and others are thinking about doing so. Well, if at some point you want to send us an email about your experiences, we would love to share that with the rest of the network. And we have reached the end of our time, and I want to be respectful of that. So thank you again, Marisa, for your time and for sharing your expertise on this call. And I'm sure after we hang up, we're all going to think of a million more questions we'd like to ask you. So you may be hearing from us again.
I'm more than happy to answer any other questions that you all have, so feel free to reach out.
That's wonderful. Thank you so much. And to those of you on the call, please don't forget to respond to the survey link when you hang up. You'll be getting that link in your email. It's really helpful to us for your response. So that concludes our webinar for today, and I wish all of you a very wonderful afternoon. And thank you again, Marisa, and thanks to all of you who joined us.
Thank you.
Thanks. Bye-bye.
The host has